Myelofibrosis, as we know, is a disorder of the bone marrow, and for most of those, allogeneic stem cell transplant is the only potentially curative treatment, which it is for myelofibrosis. We now have more drugs in the myelofibrosis space that can improve the symptoms and splenomegaly, and even cytopenias, I guess, to some extent. But none of them are curative options, and none of them change the natural history of myelofibrosis, which is to transition into acute myeloid leukemia. And that is where the role of allogeneic stem cell transplant comes in. Out of the patients that are seen in clinic, we consider most of them for an allogeneic transplant if they are eligible and if they have a higher risk disease. So the indications for allogeneic transplant in general are considered to be higher risk disease, at least intermediate 2 or high risk by the DIPSS plus scoring system, or if they're having a lot of issues with transfusion dependence and transfusion requirements. And now, as we're learning more and more about the role of molecular mutations in prognosticating the disease process, that has sort of come into role in terms of prognostication using the MIPSS 70 plus or the MIPSS version 2.0 scoring system. So those are some of the factors that you use to identify patients who would require an allogeneic stem cell transplant, and then we use the usual screening for the patient, identifying their age, organ dysfunction, to see if they are good candidates for allogeneic stem cell transplant. That's usually probably around half of them at least.